Okay, so gastritis, as we've said, inflammation of the stomach. So, what are the symptoms of gastritis? It's usually upper abdominal pain, epigastric pain. Often you'll have more burping than usual. You may have some nausea. Uh, when you eat, it bothers the stomach because you're putting food onto an irritated stomach lining. So what causes gastritis? Because remember, I mean, your stomach has a pH of 2 to 5, say. So it's very prone to getting irritated just by the fact that it already has a lot of acid in it. So medications, so non-steroidal anti-inflammatories, very common drugs that people use, tough on the stomach. They can lead to gastritis and ulcers. Aspirin, same thing. Gastritis, ulcers. Steroids, so prednisone, dexamethasone. We use these drugs very frequently for many conditions, and they can lead to gastritis. Alcohol, it's a direct irritant to the stomach, so it'll inflame the stomach lining. H. pylori, which is a bacteria that can live in our stomachs and inflame the stomach lining, and we'll talk more about that. There is a condition called atrophic gastritis. It tends to happen as we get older, and you could think of it as, I mean, it is an autoimmune disease. It's basically you're producing antibodies that attack the lining of your stomach. So it does two things. It can lead to gastritis, but it can also lead to a reduction in intrinsic factor production. And if you don't have intrinsic factor, you're unable to absorb vitamin B12, and that particular condition is called pernicious anemia, when you can't absorb B12 due to absent intrinsic factor. Smoking, as mentioned before, smoke has a lot of toxins in it. When you swallow those toxins, they can irritate the stomach. NG tube, just by the very fact of having a tube rubbing against the side wall in your stomach, can cause some gastritis. Physical and psychological stress. So let's say that you have something, there's a patient that has severe burns, or they've gone into severe renal failure, or they're septic, meaning they have bacteria in their blood, and their blood pressure is low, and they're confused. So any severe illness, the body can't cope with this very acidic environment. It's not as protective. It's not producing as much mucus because it's focusing on this acute illness that you have. And you can get what are called stress ulcers or gastritis. So gastritis from a severe illness, we will put people on proton pump inhibitors. So if an old person comes in and they're severely burned, we'll automatically put them on some kind of an antacid to protect their stomach, because we know that there's a very high chance of developing gastritis or a peptic ulcer in an acute illness. Okay, so peptic ulcers are the umbrella for stomach ulcers and duodenal ulcers. So gastric or duodenal ulcers are called peptic ulcers. So, there's a bit of mythology here. Gastric ulcers usually cause pain after eating. So worsening of pain after eating, compared to a duodenal ulcer, which tends to get a bit better after eating, and then gets worse when you're not eating. So I think it's probably important to remember these concepts for testing purposes. In real life, so I'm giving you a bit of real life and things you need to know for testing purposes. In real life, we would diagnose where the ulcer is with a gastroscope. we would not rely on, well, it's a bit better after an hour and it's a bit worse after 3 hours. We can't rely on that. But for testing purposes, just know that gastric ulcers typically get worse when you throw food into the stomach because you're aggravating the stomach lining. And the duodenal ulcers get a bit better after eating because you're reducing the pH. So when the food flows into the duodenum, it's lining the ulcer and making it, reducing the symptoms coming from it. Okay, so I can't explain it any better than that. Just, we rely more on gastroscopes in real life, but yeah, try to just in your mind try and figure out a way to understand which one's worse with eating and which one's better with eating. So here's an image of the stomach and the duodenum, and in the left diagram you can see two ulcers. This person's having a bad day. Two ulcers, one in higher up in the stomach, and one in the middle of the stomach there, and there's a duodenal ulcers. Gastric ulcers create a bit more concern for us because gastric ulcers can also be caused by a gastric cancer. So whenever we treat a gastric ulcer, we typically have a follow-up scope or a follow-up imaging test to make sure that it's completely healed, because sometimes a gastric cancer can be within the ulcer. Okay, duodenal ulcers don't behave that way. You don't get duodenal cancers. So gastric ulcers warrant a follow-up scope. Duodenal ulcers don't. And ulcers, whether they're in the duodenum or the stomach, are really treated the same way, and we'll come to that next. Actually, why don't we just look at this slide? So when we're looking at this slide, let's just think of what could happen other than the pain this person's having. What bad can happen with one of these ulcers? So what if the ulcer continues to bore through the stomach or the duodenum? Okay, you'll get a perforated ulcer. So a perforated ulcer means that you now have a hole into the peritoneal cavity, and that's peritonitis. So you're leaking acid and food into the peritoneal cavity. This person will become very sick very quickly. Okay, they typically need surgery to repair the perforated ulcer. They need IV antibiotics to treat the peritonitis, and they're often in the ICU because they're quite unstable. What's another complication? What about bleeding? One of these ulcers hits an artery and suddenly it's just spurting blood. So you're either vomiting blood, hematemesis, or you're having blood go out your anus, the bottom end, and it's melena. Okay, so bleeding ulcers are another complication. So this next slide on the cause of peptic ulcers is really interesting. These two researchers discovered this bacteria called Helicobacter pylori, H. pylori, and they presented their research at a conference, and they were essentially laughed off the stage. And I think for a year or two, people thought they were, in the gastroenterology world, people thought they were crazy. And it actually came to be true that Helicobacter is one of the main causes of gastritis and peptic ulcers. And this is a very hardy bacteria that can live in a very acidic environment of the stomach and lead to inflammation of the stomach that can also lead to a peptic ulcer. And that's what started the era of treating ulcers with antibiotics. So this cartoon, I think it's a great little image here. So this is just showing you H. pylori, which is the small bacteria that can live in people's stomach that's irritating the gastric lining and leading to gastritis and peptic ulcer disease, gastric ulcers and duodenal ulcers. And this is the most common cause of peptic ulcers and gastritis, and we treat it with an assortment of antibiotics, typically a penicillin like amoxicillin and another one called metronidazole. If you're allergic to a penicillin, we'll use something called clarithromycin and metronidazole. Also, we use Pepto-Bismol, which is bismuth, because this particular bacteria really hates being around bismuth. So Pepto-Bismol is often added to the treatment plan, plus a proton pump inhibitor. So you can see it's 2 antibiotics plus bismuth, which is Pepto-Bismol, plus a proton pump inhibitor, and typically for 14 days. So it's quite a few medications to clear the stomach of this stubborn little bacteria. Okay, so let's do this question together. What symptom would you expect from a duodenal ulcer? So I think I mentioned before, I'm not a big fan on trying to figure out a duodenal ulcer from a gastric ulcer. I know sometimes we try and figure out by taking the history, which one is a duodenal ulcer, which patient has a gastric ulcer. I'm going to tell you in real life, it's next to impossible until we do an upper gastrointestinal scope called a gastroscope. Okay, so let's just do it anyways though. So pain triggered by eating, well, that's typically more frequent with a gastric ulcer. Weight loss shouldn't really occur. Weight loss is more concerning for cancer, such as a gastric cancer. Okay, we don't see a lot of duodenal ulcers, by the way. Heartburn. Heartburn isn't really associated with duodenal ulcers, right? So heartburn is acid refluxing back into the esophagus. And lastly, pain occurring at night. So this one can occur. You're not eating or drinking anything that's buffering the pH in your stomach, so the acid can then drip from the stomach to the duodenum and irritate a duodenal ulcer. Okay, so even though I know you'll see in the textbooks this distinguishing between gastric and duodenal ulcers, and likely for testing purposes it's important, I'll just tell you in real life it's a coin toss almost, figuring out duodenal versus gastric ulcers. Now, before we get to gastric cancer, I did want to mention something on the previous slide about H. pylori. So there's different ways of testing for this bacteria. One of the more common ways is when a gastroscope is being done, biopsies are taken for this bacteria to see if it exists in the tissue. So that's a common way. Another one is what's called a urea breath test. So because this bacteria produces urea, we can pick it up on a breath test. When you're breathing, we can pick up elevated levels. So a urea breath test is to also check for H. pylori. We can do stool samples to check for an antigen that the bacteria has on its cell membrane. So stool sampling can also be useful. And lastly, we can take blood tests to see if you've produced antibodies against this bacteria. So serum testing. So there's an assortment of ways of testing for this bacteria. Okay, on to gastric cancer. So gastric cancer is definitely a concerning cancer, and it's a malignant cancer that's growing out of the stomach wall and filling the stomach in terms of its size. So one of the first symptoms of gastric cancer is I can't eat very much. My stomach fills quickly. And it does because the cancer is taking up part of the space within within the stomach. So what are the risk factors for stomach cancer? So definitely smoking, H. pylori, as we've discussed. Men typically get it more than women. Age over 60, that would go for pretty well every cancer, but age over 60. Smoked and pickled foods, those are irritants. So smoked foods, smoked fish, pickled foods are irritants to the stomach, so they can cause a gastritis and also lead to stomach cancer. Family history is very important in stomach cancer. If you have a strong family history of stomach cancer, that can be a definite risk factor. Obesity is an independent risk factor for gastric cancer, and that's just through having studied different risk factors. So anything that causes irritation of the stomach can also lead to cancer because the cells are having to continually divide. And finally, over the years, one of them makes a mutation that leads to a gastric cancer. Okay, so these are the typical risk factors.